I'm Dr. Deepak Chopra, and just wait till you see this extraordinary conversation that I'm having with my very special guest, Dr. Robert Montgomery. If anyone is in the surgical or medical field or knows anything about transplants, then they know who Dr. Montgomery is. He's a professor at NYU at Langone School, and he's probably the most famous transplant surgeon in the world. You'll see all his accomplishments in the biography below. I don't want to spend too much time talking about that because then there's so much to say that will take up the entire interview. So welcome to this conversation. Thanks for doing it, Dr. Montgomery.
Thanks for having me.
And before we get into the conversation, just a few words. Right now, you're in New York City. Tell us about your practice, what you do.
Right. So, I do primarily kidney transplants these days. I'm sort of a one-trick pony now. I used to do all the different transplants. And that's mainly because I have a lot of other roles now. I'm the chair of surgery at NYU Langone, and I'm also the director of the Transplant Institute. So I've got a significant administrative role. I run a big research lab that's focused on xenotransplantation, so transplanting pig organs into humans. And then, of course, I take care of my own patients one at a time. So that's kind of how I spend my time.
Where did you go to medical school, sir?
The University of Rochester in
see.
New York, yeah.
And your surgical training?
All at Johns Hopkins.
I see. So to be a transplant surgeon, you have to, of course, know all about immunology and biochemistry and all the other disciplines because it involves so many things.
It does. And I did do a PhD, or what's referred to as a DPhil, in England at University of Oxford. So I took time out and did a degree in molecular immunology.
Okay, well, there's a lot to talk about what you do as a surgeon, as a physician. Maybe we should have that conversation too, because you have a wealth of experience. And also you created something called the kidney matching program. Tell us a little bit about that.
Sure. So, throughout my whole career, I've been thinking a lot about how to solve the biggest problem, our number one problem, which is the shortage of human organs for transplantation. So believe it or not, each year we're only able to transplant about 3% of the total number of people, and you can just name the organ, it's all the same, who could potentially benefit, who have end-stage organ disease. And that's totally because we just don't have enough organs. And it's highly rationed. It's probably the most highly rationed thing in medicine that really works and is better than any other of the alternatives. Only about 10% of the people with organ failure make it onto a transplant list. And then only a third of them ever get a transplant. So my whole career has really been trying to address that problem. And I did it, I think, initially through incremental improvements in the current paradigm, which is that someone has to die in order for somebody to live, which unfortunately is a broken paradigm. And then there's some organs where a living donor can donate an organ or part of their liver, for instance, to save a life. So in the early part of my career, I was really focused on living donation and specifically on living kidney donation, because I really thought that was something that we could expand to fill some of that gap between demand and supply. And so the first thing we worked on was a better operation for the donor. So the original operation was quite morbid. It involved a big incision. Actually, the recipients would go home from the hospital before the donors. So that's how big the operation was. So we used minimally invasive techniques, designed a new operation, the laparoscopic donor nephrectomy. It's now the standard throughout the world.
Without cutting open the patient.
Well, we just make small incisions, just a big enough incision to deliver the organ. So it's sort of like delivering a baby almost. We actually use a C-section incision to take the kidney out. And that works really well. The people leave the hospital in 2 days, the donors, and they're back to work in 2 weeks. So that really revolutionized the donor operation, made it much easier to donate. And initially, a lot of people came forward who maybe were ambivalent, about donation because of the magnitude of the operation. The second thing that we developed was a way of getting around this problem that about 35% of the people who have a willing donor can't accept their organ because they're either tissue or blood type incompatible. So there's, if you wanted to give your kidney to me, there would be a 1/3 chance that you wouldn't be able to do that. So we figured out 2 ways. One was to remove the antibodies from the recipient that we have. They're called natural antibodies that would immediately attack the organ if it was a different blood group or if we were tissue incompatible. And the other is to just go around the problem. In other words, you would give your kidney to, say, a person who you didn't know, who then their donor, and they're incompatible, their donor would give a kidney to me. And you swap the kidneys.
Swap the kidney.
And the big breakthrough was in 1998, a woman came forward who actually had been thinking about donating a kidney, heard about the new operation that we had just created that made it a lot easier to donate, and said, okay, now's the time to do this. But she didn't know anyone who needed a kidney. So she came to us and said, I'll give my kidney to anyone who needs it. And believe it or not, every year there are about 500 to 600 people who do that now. And she was the first one, and we gave her kidney to a child because children are most adversely affected by kidney disease. The next day, 50 people called in because she was on the nightly news and said, I want to do what that lady just did. And this started this whole wave of altruistic donation or non-directed donation. I think all donors are altruistic. But so anyway, we were thinking about this swapping, about removing the antibodies, different ways of getting these people transplanted, and had sort of a eureka moment, which was we can have a non-directed donor give his or her kidney to someone who is an incompatible donor, and then their donor can give their kidney to the person at the top of the list. But it's not just limited to 2 transplants. You could continue this sort of domino and get, many people transplanted from that one altruistic gift.
Amazing.
And those donors love it. The idea that their gift can make multiple transplants possible is something that the donors really
It's a very
appreciate.
creative idea.
So now, since we first came up with this idea, 10,000 people have been transplanted through that system. But the sad truth is the total number of living donors has not changed. Even though we've had these big, innovations that have made it easier to donate, the total number of donors every year has been stagnant. So when I was going through, and we'll, I'm sure, talk about this, my own waiting time for my own transplant, because I've had a heart transplant, I realized that this was a broken system, and that despite, great intention, and for the people who are lucky enough to get a transplant, it's life-changing. But we're only able to deliver that to a very small number of people, and the others lose out. So it became crystal clear to me that we needed another source of organs, that the system that we had socialized this idea over the past 60 years, that we had this wonderful thing that could only become available to a small fraction of the people who needed it. And we needed a renewable, unlimited supply of organs. We could really change the whole thing. And that's when I began to focus. When I woke up from my transplant, I said, okay, this is my borrowed time, and I'm going to spend the rest of my life trying to solve this problem of finding another source of organs.
And you did. That's the pig.
With a great team, yeah.
So now you're using pigs as organ donors, basically.
Gene-edited pig organs, yes. And we have a woman now who's 4.5 months out from a transplant from a 10 gene-edited pig.
And she's doing well.
Yeah.
Well, that's a whole conversation,
Yeah.
talking about gene editing and so on. And I'm sure we'll have that one of these days.
Yes.
We met briefly in Lake Nona and then at a dinner for Harvard School of Flourishing.
Right.
And you told me about your family history of heart disease.
Yeah.
First of all, what is that family history? What is the gene and what is the disease?
Sure. So, when my father died from dilated cardiomyopathy, he was 52.
How old are you, sir?
I'm now 65. I was 58 when I had my heart transplant. We thought, the medical field, thought this was a virus that attacked his heart. Cardiomyopathy is not what you normally think about when you think about heart disease. It doesn't involve the coronary arteries. It involves the muscle of the heart. And the muscle starts to scar and dilate. That's the natural compensation that the heart has when it starts to lose function. And then it becomes very unstable from a rhythm perspective. So sudden death is a big feature of the type of heart disease that my father had, and which now we know is genetic.
So there are many types of cardiomyopathy.
There are many causes of cardiomyopathy.
Correct. And this is one specific genetic mutation.
It's a difference in one of the building blocks, in a protein that's involved in joining some of the big cardiac proteins together. It's called a splicing gene. It's as if, if you took a phone book of a metropolitan area, and that's the genetic code, there would be one phone number that was wrong, and it would be one digit in that phone number. So,
and that's the nucleotide.
And that's the nucleotide. So it's a single nucleotide substitution that results in a change.
You said
in
digit.
amino acid.
I'm thinking you could even digitally code that anomaly, right?
Yes.
Ultimately, as a combination of zeros and ones.
That's right.
Okay, what's this particular cardiomyopathy called?
It's familial dilated cardiomyopathy. The mutation is called RBM20.
I see. And what you discovered is that a brother of yours also had this, right?
Yeah, so when I was an intern a surgical intern, I got a call from my sister-in-law. And she told me that my 35-year-old brother, Richard, had just dropped dead on a family vacation. And he was water skiing at the time. No indication before that there was anything wrong with him. And I had his heart sent to Johns Hopkins, where I was training. And they examined it and said, this is dilated cardiomyopathy. It's the same disease.
So that's when, but did you know about your father having that?
We knew he had dilated cardiomyopathy, but we didn't think it was genetic. Back then, most things in heart disease were not thought to be genetic. So they thought it was a post-viral syndrome. But, then it was clear. And then, so I'm one of 4 boys. So Richard, had this sudden death at 35. Another one of my brothers, then 8 years after Richard died, he needed a heart transplant. He was 39, and it's 30 years later. He's still alive and doing well. I got on a treadmill, and at my peak.
There's one brother missing here.
Yeah, the other brother doesn't have it. It's what's called an autosomal dominant. So it's like a coin flip with each child.
Is it just males or?
No, it affects. We have women who are affected now in the family. Now that we know the gene, we can screen, all the children. And so we know who has it and who doesn't.
Do you think at some point in the future there'll be gene editing for this kind of thing?
I think what I've been told by some of my colleagues who are researching this is that it's very amenable to CRISPR edit. So I think in my lifetime, hopefully, we'll see that. But certainly
CRISPR is
in my
already approved for a few things.
Yes.
So that's good news. So one brother is fine. When did you find out that you had?
So it was right after Richard's death that I got on a treadmill, and at peak performance, I had a run of a very bad dysrhythmia called ventricular tachycardia, and it was clear. And given the family history and an obvious physical sign, they recommended that I get a defibrillator. Now, it was right at the very beginning of that technology. It had just been invented at Johns Hopkins, where I was a resident, a surgical resident.
So the diagnosis was made at the age of
I was 29.
Oh, and you waited till you were 58 to have your transplant.
Well, so the defibrillator would theoretically protect me from a sudden death. And my heart function at the time of diagnosis was still okay. It wasn't what it should be, but it was still fine. I was asymptomatic, but high risk of sudden death. So they gave me this experimental device, had to be implanted in my abdomen. So now, of course, a defibrillator is the size of a quarter, and it's up in the shoulder, and you hardly even know anything about it. It was a big deal then. They had to open my chest, put 2 patches around my heart to deliver the shock when I would have
Arrhythmia.
Yes, a dangerous arrhythmia. They told me that it really wasn't compatible with being a surgeon and probably not a doctor at the time, and suggested that I look at another profession. I had some really good mentors who stood behind me. I was about to go to Oxford anyway to do my PhD, and they held my position, in the residency, and said, we'll do the surgery, and let's see how you do. And if, in 4 years you're okay, we'll allow you to continue your training. So when I got back, one of the big concerns was I was the first surgeon in the world to get one of these devices. We know that if you operate on someone who has the device, the electric cautery that we use for every operation will cause it to go off. So they thought, the engineers thought, if I was holding the electric cautery, it would trigger a shock. And a shock is like getting hit in the chest with a baseball bat, basically. And so, that's one of the reasons they said I couldn't operate. I went to the electrophysiology lab with all the equipment from the operating room, and we tested everything, and it was fine. And so I was allowed to continue with my training.
And then at the age of 58, you had a transplant.
I did, but before that, I would describe that journey over 30 years. It was 30 years. It was periods of relative stability that were punctuated by near-death experiences, and I had 7 deaths. And the first one was when I was 50. I was saved by the defibrillator.
What were you doing?
I'm an outdoorsman, so I was actually in Patagonia. I was in the middle of a terrible snowstorm. I was walking with, my son and a couple of guides, and I sort of fell behind as we were climbing this mountain. And they couldn't see me, and I was starting to have the sensation that I was having a dangerous arrhythmia. And then lights went out, and when I woke up, I had fallen a distance and had cut my face, and there was blood all over the snow, and my son was standing over me and, asking if I was okay. So that was the first time.
And then you were transferred to a hospital. What happened?
No. When this happens, that's a good outcome, right? And there's really not much to be done, honestly. I was on optimal medications to try to prevent that. Perhaps not climbing a mountain, in the middle of a snowstorm would have been a good idea. But I had decided a long time before that I was just going to live my life, whatever I had. I kind of set in my mind that if I got to 35, that would be a huge bonus, because I was sort of basing, what to expect on what happened to my brother. So, I have continued to embrace life. So the second time it happened, I was in Patagonia again, and it was 6 years later.
And now you're how old this time?
So now I'm 56.
No, second time you had the...
Yeah.
Okay.
And, my heart disease was progressing. The function was starting to go down. And when I got down to Patagonia, I had a bronchitis. I had a chest infection when I arrived there. So I started to develop rigors, shaking chills, bed shaking chills. And I clearly had bacteria. I could tell, I could easily diagnose that I had bacteria in my blood. And I had a cardiac arrest, and my son did CPR on me. And my device didn't go off. They threw me in the back of a pickup truck and drove me to a tiny little hospital. We were in the middle of nowhere. And they took one look at me and said, "There's nothing we can do for this guy." Put me in an ambulance and drove 5 hours to another tiny little hospital. And I spent a month in a coma in that hospital. Was definitely sicker than what they were used to taking care of. And it wasn't until they felt that I was stable enough that they were able to airlift me out.